So I thought I would just have a little bit of fun just before the reception and do some board review practice and use some clinical images and some cases. I do think it would be great. I think there are about 100 people in this room that you use the clickers, and we'll see how many people are using them or not. So let's get going. Can't advance the slide. So this is case one. This is a 69-year-old woman with 3-month onset of malaise and weakness who presents with anemia. I put anemia in there. Hemoglobin of 8.9, diffuse achiness in her bones, and on workup, a serum creatinine of 3.8. A renal biopsy is performed. This is what the biopsy shows, you see here. And you are asked to make the diagnosis. A, light chain deposition disease. B, phosphate nephropathy. C, uric acid nephropathy. D, CAS nephropathy. And E, fibrillary glomerulonephritis. So only 26 people are responding? We got to get that rate up. I'm going to have to check on you guys. So you're right, D. This is CAS nephropathy. So multiple myeloma is, as you know, the malignant proliferation of plasma cells involving more than 10% of the bone marrow. And these patients have bone pain, which was mentioned in the history, which is related to multiple lytic lesions, and it's the most common presentation. Up to 30% of patients are diagnosed incidentally while they're being evaluated for other things. A third of those patients are diagnosed after a pathological fracture, commonly of the axial skeleton. The overproduction of light chains results in tubular capacity for reabsorption being exceeded, then filtered light chains and immunoglobulins bind to TAM horse valve glycoprotein, and CAS formation of obstruction occurs in the distal nephron. And if I go back and show you, these tend to be this material here in the tubules, and they have this fractured appearance to them. That's typical. So when you see this fractured appearance like this, there's only one thing you should think about, and that's CAS nephropathy in patients with myeloma. In the history, of course, you see this is very common, this presentation, this prodrome of malaise and weakness, anemia, obviously, diffuse achiness in the bones, and then renal failure. Okay, case number 2. This is a patient of mine. This is a 52-year-old woman who underwent thoracoabdominal resection of a right adrenal cancer, a right periadrenal lymph node dissection, and resection of the inferior vena cava. Her baseline creatinine was 0.9 milligram per deciliter. 10 days after surgery, she presented with right flank pain, foul-smelling brownish drainage from her drain that had been in place from the time of surgery. Blood pressure was 140/82, her temperature was 100 degrees Fahrenheit, white count 17,000 and change, hematocrit 23%, creatinine of 1.6. And the syndrome that you're describing here, and you can see this is the CAT scan here, and you see the two scans here. The diagnosis is either Alagille syndrome or Page kidney or Benjamin syndrome or Brody abscess. I got to have more than 26 people. Let's break that record. We're improving. Still 31% of the people in this class are actually responding. I don't know what you other guys are doing. So, how many people guessed? Just raise your hand. 1, 2, be honest. How many people? About 30 people guessed. That's why. So this is a Page kidney. So in 1955, Engel and Page reported a case of hypertension associated with a renal subcapsular hematoma in a football player who had sustained blunt trauma to the flank. And this was the first clinical correlate to Page's 1939 study of hypertension induced in dogs by wrapping one or more kidneys with cellophane. So that's what the Page kidney is external compression of the kidney causing renal hypoperfusion and ischemia. And causes include bleeding secondary to trauma, surgery, a cyst, or tumor. And so in somebody like this who has some sort of surgery that's occurring, you're going to wonder about the fact that there's some surgical complication, right? That's the thing you're thinking about. The fact that there's foul-smelling drainage from the drain suggests that there's some sort of an infection or an abscess. And with the hematocrit of only 23%, you're going to think that this patient has had a hematoma that's become infected, right? And she's febrile, right? So there's an abscess, probably an infected hematoma that become an abscess. And what's happening is there's compression going on, right? And you can see that here, where you can see the difference between one kidney versus the other in terms of renal flow, right? And that's what a Page kidney is. And here, I think you can see that there is compression going on, okay? So the CT of the abdomen is the preferred imaging modality because renal ultrasound may not be sufficiently sensitive. In the case presented here, the MAGSET scan was used to assess the split renal function. And all of these are all just distractions. I just put it out there just because I just thought up names and thought that people are going to guess, and so you'll guess some, right? They've got nothing to do with this, all right? Case number 3. Okay, 31 people. You gotta. Who's sleeping? Just raise your hand. Come on. We got to get to 40 at least in this one. Case 3. A 52-year-old homeless man on chronic dialysis with a history of non-compliance presents with chest pain. Chest X-ray and EKG show the following. And you can see the chest X-ray here and the electrocardiogram here. The next step should be administer prednisone, 60 milligrams per day, tapered over 1 month. B, emergency pericardiocentesis, initiate heparin-free daily dialysis. C, anticoagulate the patient immediately with heparin. D, administer colchicine. And E, administer vitamin B6. We've got a steady 31 people. We're not going to get better than that. You're just not convinced, right? So what was the answer there? Do you want to repeat it? I didn't see it. Pericardiocentesis. 90%! Wow. Great. Everybody's going to pass the boards. So this is emergency pericardiocentesis and initiate heparin-free daily dialysis. So the electrocardiogram shows electrical alternans, sinus tachycardia with beat-to-beat variation in the QRS appearance. And it's best seen in V2 and V5. And you can see that here in V2 and V5. Now, pericardial inflammation from uremia resulting in tamponade, what are the things you need to know? In uremic pericarditis, there's an inflammation of the visceral and parietal membranes of the pericardial sac. Usually the BUN is greater than 60, but not always the case. You can get very malnourished patients who have BUNs much lower and still develop pericarditis. Risk factors include inadequate dialysis and fluid overload, and that would be the telltale thing. This patient had a history of non-compliance. Patients usually complain of fever and pleuritic chest pain, worse than the recumbent position, and the pericardial rub is generally audible but is frequently transient. And this is the typical thing. You're rounding with the house staff or with the fellow or with a colleague. They hear the rub and you go in and you don't hear it. And you tell everybody, I didn't hear it, and what do they think? Your physical diagnosis skills aren't good, or you're too old, or you haven't kept up with your physical diagnosis. They don't give you the benefit of the doubt and say, gee, maybe that it wasn't there at the time you listened to it, right? So what do? You say, it comes and goes. Signs of cardiac tamponade may be seen in these patients, particularly in patients with rapid pericardial fluid accumulation. The electrocardiogram does not show the typical diffuse ST and T wave elevations observed in other causes of acute pericarditis. For example, Dressler's syndrome, post-MI, right? This is the post-MI concave up ST segments. This is because of the lack of penetration of inflammatory cells into the myocardium, right? So that's why you don't see that. So typical features of pericarditis are you're not going to see the typical ST segment changes. That's very important. If you see it, it's more likely not to be uremic pericarditis than it is pericarditis. If you are seeing EKG changes, you're going to see, keep an eye out for electrical alternans with a sinus tachycardia and this beat-to-beat variation, very typical. And don't worry about the fact that you may or may not hear the rub. Okay, case 4. We're going to beat 31. So these are the 3 pictures, and the question is, what is the most likely diagnosis? Correct. D is correct. So most people, 57% of people got there. We're still the 31 people who are responding. We're not going to make any progress. And this is membranous. And quick card on membranous, subepithelial immune deposition. Etiology, unknown, although I'll tell you a little bit about what's known, which of course you've heard from people already. So there are secondary causes, and there are a whole boatload of secondary causes, but the common ones are hepatitis, B and C, gold, classic, penicillamine, non-steroidals, toxins of various types, and autoimmune diseases. In 2/3, the causes are not known. Less than 5% of the pediatric population have membranous. In the pediatric population, commonest cause of nephrotic syndrome is minimal change disease. In adults, 30% of adults with nephrotic syndrome, particularly 50% of older adults, will have membranous as the cause of nephrotic syndrome. And there's an increased risk with a particular HLA DR3. Idiopathic, insidious onset, more common in males than females. 80% have nephrotic syndrome at presentation. About 20% are asymptomatic. They have non-nephrotic proteinuria. Like with anything in life, some patients will have a milder form. They tend to have a better prognosis. About 50%, about half of the patients have hematuria. And so just because you have hematuria in the context of proteinuria, don't think that this is absolutely not membranous. Can be membranous. You have membrane defects. Hypertension is not common, unlike FSGS, and FSGS hypertension is actually the norm. And there is, in particularly patients with severe hypoalbuminemia, particularly when the albumin is less than 1.5, you have an increased risk of thromboembolism, 15 to 40%. In these patients, use of at least at a minimum aspirin, but perhaps low molecular weight heparin and strategies to reduce proteinuria and repair the leak are very important. And over time, particularly with patients with large amounts of proteinuria, there can be an insidious decline in GFR. Remember the PLA3 story? I think you may have heard that already. I don't have time to go over that. So what's the diagnosis here? This is, for those who are not paying attention, this is a fundus. And the questions are, which one of the following is it? A, central retinal artery occlusion. B, diabetic retinopathy. C, ocular toxoplasmosis. D, optic neuritis. And E, malignant hypertension. So about half of the people got E, and about half of the people got B. So 27 people. You know, there were only 2 really important possibilities, right? You look at this and you say it's either diabetic retinopathy or hypertensive retinopathy. Now, most of you didn't see what the answer was because it was given here. And this just shows you that you don't pay any attention to what's on the slides, because this is the source, and the source says diabetic retinopathy. So the 52% of the people who did not get this right should get up, go to the bathroom, wash your face, and come back. So this fundus shows findings consistent with diabetic retinopathy. And there you see microaneurysms, dot and blot hemorrhages, flame-shaped hemorrhages, hard exudates with retinal edema, cotton wool spots, the whole 9 yards, right? This is a typical feature of somebody with advanced diabetic retinopathy. And I'm not going to go through all of this in detail, but this explains what each of these are. But perhaps the most important lesson in this slide is to read the bottom of the slide. But key features in diabetic. Now, I know nobody goes around carrying an ophthalmoscope anymore. Those are for the history books, right? We look at our patients in the eye and we can tell what's in the fundus. But for those of you who carry ophthalmoscopes and practice this, you will come across the odd diabetic patient with all of these changes, and it's worth actually looking in the eye, because some of these patients will get blindness if you don't act and refer the patient to an ophthalmologist right away. And then besides that, occasionally you'll see a patient who might have a hypertensive emergency and not being able to see crisp, sharp, a sharp cup, the margins of the cup, optic cup. You will not be able to convincingly make the diagnosis of malignant hypertension. So it's actually worth looking in the eyes. The urine sediment shows what form of crystals in this slide. Yeah. So that's exactly right. This is a patient with cystine crystals. You do not need to know anything about cystinuria, in my opinion. Other than know that the crystals that you see are absolutely clearly cystine. They're hexagonal, translucent, and they have this sort of funny stuff in the middle. It's a little bit dysmorphic in the middle there. These are classically cystine crystals. There's a lot of explanation of how you get cystinuria, but if you have cystinuria and you see these crystals and nothing else like it, they're not envelope-shaped. I don't have envelopes like this. They're not coffin-shaped. Nobody gets buried in things like this. These are cystine crystals, hexagonal crystals. Okay, this is case 7, a 22-year-old woman with joint pain and abdominal pain and a rash. Rectal examination shows some blood. Urine shows hematuria. You see the rash. You see the blood in the urine. The question is, what's the diagnosis? Great, we are moving up to 33 people responded. I'm really glad. This is Henoch-Schönlein-Pupper, mostly everybody got it. When you see syndromes where you've got joint and abdominal pain and a rash and kidney involvement, it's going to be HSP nephritis, 99 times out of 100. This is all about pattern recognition. You don't even need to see whether they're dysmorphic red cells. Just this pattern should make you think about HSP nephritis. And so that's the correct answer. And I'm just going to show you, this is the pathology. This is an IgA pattern. And you see on immunofluorescence IgA on the distribution of the immunoglobulin. There are 4 things that these patients have. This is the pattern you've got to recognize. Skin problems, a purple non-blanching rash with purpuric papules. Biopsy will show a leukocytoclastic vasculitis. Renal, you get glomerulonephritis, which is an IgA pattern, most common in adults, 63% of adults, and they have present with hematuria, proteinuria. GI, you get a small vessel vasculitis in the small bowel. That's what causes the abdominal pain. And joints, you get arthralgias, and periarticular edema, but you do not get arthritis. You do not get deformities either. Case 8. This is kidneys. These are kidneys. What is the most likely diagnosis? Yep. So this is somewhat discriminatory. Most people got it. This is renal tubular acidosis. Primary hypoparathyroidism doesn't lead to hypercalciuria, but you need calcium in the urine, and you're filtering through to cause this nephrocalcinosis that's seen on these plain abdominal X-ray. Familial hypocalciuric hypercalcemia, you don't have calcium in the urine. Salicylate overdose, you will not, this is an acute abnormality, it's not going to cause this. This is a chronic thing. Paget's disease can be associated with hypercalcemia, but this is not the commonest cause of it. So this patient had renal tubular acidosis at the age of 9, didn't follow up, undergo medical follow-up, and the other causes are not common causes of nephrocalcinosis. So just remember, this is renal tubular acidosis. The most common one that would cause this would be distal renal tubular acidosis, which is a classical form of RTA. And this was described first. So it's called type 1. And these patients have hypokalemia, hypocalcemia, and hyperchloremia, but they get urinary stone formation related to alkaline urine, hypercalciuria, and a low urine citrate, and they typically present with nephrocalcinosis. These children have rickets. So this is a immunofluorescence, and the question is, what's the most likely diagnosis? Yeah, so that's correct. So this was described by Ernest Goodpasture, or Goodpasture syndrome, who's a resident of the MGH Path Department when he did his original discovery in this. He was moonlighting at the Chelsea Naval Hospital. Even to this day, we have nephrologists and pathologists on staff who are moonlighting at Harvard. Sad. Reported autopsy findings in young sailors. This is the reference in American Journal of Medical Science in 1919. He went on to become quite famous as a chair of the Department of Pathology at Vanderbilt. In 1958, Stanton and Tang used the term Goodpasture syndrome, hemorrhage, and glomerulonephritis. And in 1964, Shear and Grossman reported linear staining by immunofluorescence. It's an uncommon disease. I've seen in the last 30 years 4 cases. I would say if you did the board exams in nephrology, you will see them over the 30-year span, you'll see it 6 times in the boards. It's very common. Why? Because it's a medical emergency. You've got to recognize it, and you've got to treat these patients. If you sit on these patients and they can either die because of the pulmonary hemorrhage, or their creatinines get so bad that you can't rescue them with therapy. So it's something you've got to act, and that's why it comes up in the board so much. Slight preponderance in males, more common in whites over African Americans. Even though usually you think of ANCA-associated vasculitis as where you would expect to see the prodrome, even in anti-GBM nephritis, prodrome is reported. Fever, myalgias, malaise, etc. Patients present with rapidly progressive glomerulonephritis. They have proteinuria, but they don't have, there's such a significant collapse of their glomerular tufts that the GFR goes down so dramatically that they don't have proteinuria in the nephrotic range generally, but they do have proteinuria. Hypertension is also uncommon because they don't have enough time. This is just a catastrophic collapse of the normal capillary tuft with this crescent that has developed. The ultrasound shows normal kidneys, and renal function declines very rapidly. Case 10. This is a 48-year-old white male with chronic kidney disease, CKD, with a serum creatinine 1.5 who presents to you complaining of weakness and fatigue and an episode of palpitations. Patients on furosemide 40 BID, lisinopril 20 once a day, torvastatin 20 a day, and aspirin, I'm sorry for the typo, 81 milligrams per day. You do an electrocardiogram and draw labs. Based on the ECG, what is the most likely diagnosis? So this is the ECG. I know most of us don't look at ECGs anymore, but occasionally you need to do it, right? And these are the 4 options. So most people got B, which is correct, hypokalemia. I was a little sneaky here because in the history where I gave you reasons for the patient being hyperkalemic as well, right? So the patient had, let's go back, the patient had, was on lisinopril, which would suggest they had renal dysfunction, so you could think maybe the patient was hyperkalemic. I told you the patient had weakness and fatigue and palpitations, which might make you think of hypokalemia, patients on a high dose of diuretic agent. Hypomagnesemia and hypocalcemia were thrown in as distractors. So this patient had the typical U wave, which most of you got, right? This patient doesn't have hyperkalemia because you don't have the peak T waves, which is the classic finding. But of course, there are other findings in hyperkalemia as well. But the ones that we most usually see are the T waves, at least early on. You can get widening of the QRS, flattening of the P wave, and so on. And so this is there's the different findings in these different conditions. This is the normal electrocardiogram. Patients with hypokalemia, you're starting to see this flattening here and this U wave. In hyperkalemia, you're seeing the peaked T wave and maybe a little bit of flattening of the P wave here. Hypocalcemia, you're starting to see a widening of the QT interval. And in hypercalcemia, you're seeing a narrowing of the QT interval, and you see these changes. So just keep that in mind. So in hypokalemia, the most classic is the prominent U wave, like this patient had. So hypokalemia, PR interval may be prolonged. There's a flattening of the T wave, a prominent U wave. There may be some ST depression. There may be QT prolongation, but it's not easy to measure that. Often difficult to measure because the T wave flattens. Case 11, this is a 20-year-old patient with edema, had a past history of 2 episodes of painless gross hematuria at the age of 16 and 18 years of age, denies joint pains, mouth ulcers, hemoptysis, or abdominal symptoms. Exam is normal except for blood pressure 148/92, 2+ pitting edema. UA shows 2+ blood and 4+ albumin. Sediment showed many dysmorphic red cells but no cellular CAS. Complements are normal. Renal biopsy is shown. This is the biopsy here, H&E, and this is the immunofluorescence. The most likely diagnosis, and there are 5 options. Yep, most people got this right. Whenever somebody gives you a case of IgA nephropathy in a 20-year-old male, more likely than not it's IgA nephropathy. So you just got that. You're a 20-year-old with episodic hematuria, IgA nephropathy. You should think about that. The normal complements mean that this is unlikely to be an immune complex mediated process like lupus nephritis. So it's unlikely to be lupus nephritis because of that. Anti-GBM nephritis, it's too long a history. ANCA, not the right age. And minimal change disease, the urine should be, the urine should not show these abnormalities, and B, this is an abnormal glomerulus with evidence of IgA, and this you can see IgA here. So this is not minimal change disease. So quick card on IgA nephropathy, onset usually in the 20 to 30s. It was called by D'Amico the commonest glomerulonephritis in the world. Males to females seems to be more common in Japanese males than females, more common in US, by far US males than US females. A predilection for whites and individuals and Southeastern Asians seems to be less common in African Americans. There are some familial and HLA associations. Different syndromes with IgA, macroscopic hematuria, microscopic hematuria, RPGN, and nephrotic syndrome. I've seen all of them, I'm sure you have too. Key for exams is synpharyngitic. A post-strep GN or post-infectious GN will have about a 7-day to 14-day lag when you get this autoimmune reaction to the antigens that the patient is cross-reacting with. This is not the case in a patient with IgA. So synpharyngitic as an abnormality. This is a case 12. This is a 56-year-old woman with hypertension, presents with sudden onset of painless impaired vision in the right eye. Previous day, she'd undergone cardiac catheterization for evaluation of hypertensive emergency. On physical exam, the visual acuity in the right eye was 20/100, with significant visual field defects in the inferior temporal quadrant. Oops, what is the answer here? Did you see that? Anybody tell me what it is? Yeah, there you go. So this is the boat-shaped or sort of infarct here, a patient with cholesterol embolus with the white lucency representing retinal edema. Fluorescein angiography in this patient confirmed it. You can see these little cholesterol deposition. This is actually space where it's dissolved because of the way this biopsy is prepared. And you see the foot abnormalities. You often see this in patients after they've had cardiac surgery, a blue toe, pulseless foot. You might see some livido reticularis or tenderness of the muscles. Oftentimes these are middle-aged to elderly patients, men more frequently than women. You get a stepwise increase serum creatinine. A bland urine is classic, but a paper published by Ravi Thadani and colleagues, you can actually see urine which may have formed elements like blood or white cells or granular casts. Finally, this is a 26-year-old patient presenting with a facial rash, arthralgias, and microscopic hematuria. She's not on any drug treatment. Which of the following tests would confirm the diagnosis? And these are the tests. Yep, I just leave you on a positive note. This is a patient with a malar rash from lupus. You see the sparing of the nasolabial fold. This is a typical rash. The test you would do is anti-double-stranded DNA. The differential diagnosis in a patient with a facial rash is pellagra or Bloom syndrome, and I'm not going to go into the details of why, but these are distractors. Anti-double-stranded DNA is low sensitivity for SLE, but high specificity. And basically, these patients have double-stranded DNA that are elevated. They can, almost all these patients have an ANA that's positive. My experience, if you have a patient with low complements and a double-stranded DNA that's elevated in a context of the right, rash or renal failure, you have to exclude lupus nephritis in those patients. And so in this patient, lupus nephritis is the correct diagnosis. Thank you very much.